record this as well, so it will be on the site. Let's put this on. Can I just ask you all to check that you can see my screen? Okay. Good. Okay, guys. Tonight we've got to talk about the biomechanical risk factors in implant dentistry. I thought this would be a good one. It's not going to be a long lecture, but in my view, these are the things that are going to come back to bug you as you start doing implant dentistry for a long time. You'll find that these are the sorts of most common complications that I've found after sort of placing implants for over 20 years. So hopefully you can pick up a lot of tips from this. The aims today are let's appreciate the incidence of these complications. I think over the period of time, once you get really good at placing your implants in, the biomechanical problems, essentially the occlusal problems and the geometric problems, are the things that probably are going to be more repetitive than any of the other complications. Of course, you've got the complications of peri-implantitis, but these factors that we're going to talk about tonight are going to be quite prevalent as well. We'll talk about the range of these complications. We'll talk about geometric risk. That's number of implants needed for a edentulous area and their position. We'll look a little bit more detail into the occlusal risk factors. And we'll look at prosthetic fit and the risks of cementable prosthesis. And we'll recognize the signs of overloading. I've got a little bit of a cold tonight, so I might have to stop for a sneeze here and there. Okay. What I want you to all understand is that when you're looking at these types of risk factors, that's the biomechanical risk factors, primarily occlusal and number of implants you use to restore a space, the presence of a cantilever. These are all examples of these biomechanical risks. If one of those factors exist, it might not become a risky situation. But when you start loading more and more of these factors together, then you're more likely to have a scenario where you're going to pose much more of a risk situation, and they then can develop into a major risk. For instance, if you've got a 2-unit implant bridge in a posterior segment which exhibits bruxism, and then you've got the head of the implant head, which is not set in the middle of the prosthetic crown, then you're adding to your risk factor. So you've done implants on a bruxist, and then you haven't put the implant implant head in exactly the center of your prosthetic crown. So we'll go through all of those tonight. So let's have a look. So the geometric risk is the number of implants, the position.
Excuse me.
Oh, sorry about
Microsoft Outlook.app needs your attention.
That's my computer. Apologies. The number of implants, the position of the implants, and the prosthetic design. The occlusal risk factors include significant lateral contacts in excursive jaw movements. In other words, as a patient glides from side to side, they're hitting on your implant prosthesis, and if the patient's got some parafunctional habits or tendencies. Bone and implant risk factors include placing implants in newly formed bone with no real primary stability and the implant diameter being smaller than it should be. The technological risks are the lack of prosthetic fit, and the last one is overloading. So these are all of those risk factors I was talking about. The presence of several of them lead to a much higher risk. So when you're working things out and you're looking at what's causing the problem, it is primarily a combination of all of those. It doesn't have to be just one. The number of implants used to support prosthetic teeth, ideally it should be one implant per one root support. Now, this is controversial. Do you place 2 implants in every molar tooth that you're replacing? But if you're thinking of a strictly biomechanical situation, then ideally one root has 1 implant. Now, if you're using a wide-bodied implant with a wide surface area as an implant, you can justifiably place 1 implant per 1 molar root. By splinting the teeth, splinting the implants, it's possible to use fewer implants. So therefore, by bridging the 2 implants together, it's also going to give you a little bit more surface area for the load to be distributed. So you can use, let's say, 3 implants for 5 roots. Now, 5 roots are like a molar has 3 roots. And then if you've got a premolar and a premolar, that would be ideal situation for 5 roots. Now, I'm not advocating, and I'm certainly not saying that you place 1 implant for every single tooth you take out, but what I'm saying that you understand that the ideal root support would be 1 implant per tooth, and the molar teeth being a wide-bodied and a wide implant, ideally. The molar teeth need to ideally have a wide platform, because if you have a narrow platform on molar teeth, you're increasing the degree of prosthetic extension. So in other words, you're actually placing more bonding metal, more porcelain, which is not directly over the head of the implant if you're using a narrow head implant. That just goes without saying. Placing 3 or more roots with 2 regular platform results in a geometric risk, but of course 2 wide-bodied implants eliminates that risk. So I've already said use a posterior, at the back use a wide-bodied. Out of guys who are all the guys who are there today, and you Caroline, has anyone connected an implant to a tooth in their prosthetic, in any of their prostheses yet so far? Anyone at all? Vicky, no, probably will never. Yes, Neil. Okay, well, I'm afraid you are all going to come across sooner or later in your patients something that's happened within your case where you might have to think about it. Now, my view, I know out there it's not deemed upon as perfection for not linking, but in the old days, we used to link. Now, it's not absolutely advocated the golden rule is try and avoid doing it, but there are situations where you may have to think about linking. So my official advice to you is try avoid it as much as you can. But I've done it for many, many years, and this is purely on my evidence. I have never really experienced any intrusion of teeth at the connections. But what I have done, I've always placed a stress breaker within the connection next to the tooth. In other words, I've done like a dovetail precision attachment into the female part being the tooth, and the pontic part being the pontic part having the male extension. And some of these bridges have gone on and lasted 15, 16, 18 years for me. And I've lost the count of how many I've done, probably in excess of about 100, maybe more, of these types of bridges. So I would say to you, we'll go through some cases hopefully a bit later on, that as long as you've gone through all the other options, if you're not able to put, if you've got, for instance, let's just say you've got a 6, so you've got a 6, the 4, 5 are missing, and the space is closed for the 4, and you can't get an implant in. Sorry, let's say you've got a low right 4, the 5 you can't get an implant in because the mental foramen is quite high up. You can't block graft it. You've got a 6 where you put the implant in. The 4 has got a big distal amalgam cavity. Then, if I could, I don't really want to totally cantilever off one implant because, I just don't think it's sensible. But if the 5 has got this big DO amalgam, I would put a gold inlay with the precision attachment female part into the 4 distal, do a cantilever off the implant with a fixed movable joint inside the 4. And as long as the patient can keep it clean, and as long as I've got the occlusion good, then that's a viable option. You haven't unnecessarily drilled the 4 because it's already got a large amalgam. That is an option that you should keep up your sleeve. You've all heard about tripodization. So where possible, try and put implants which go along the ridge in a slightly tripod situation. A lot of technicians, when they do their surgical guide holes, unless you tell them that you want your implants in a slight tripod arrangement, they'll give you straight all the implant heads completely in a straight line. So remember to make sure you actually write on your prescription for your surgical guides where you want the heads of the implants. Although you want the borders to be perfect, you still want them to make sure that they have a degree of tripodization in your wax-ups and then subsequently your surgical guides. In a complete arch restorations, try and spread the implants over the arch and try and avoid significant pontic extensions. Excuse me. And when you're putting the implants in a complete arch, really have a chat with the technicians about the heads of the implants and where he feels they are best located, and also talk about prosthetic extensions all the time. Try and avoid distal prosthetic extensions. Now that I know that goes against the all-on-4 principle, and I know with the all-on-4 principle, they are putting a distal extension, but their distal extension is usually just one unit. It shouldn't. In some cases, I know they put a double extension on it. My view is that you should try and limit the amount of distal extension as much as possible. But I know there's lots of studies out there that suggest that you can put more than one unit distal extension on an all-on-4. Has anyone out there done any all-on-4s yet? Chris, yet? No. Chris? So Sagendra and Chris, can I ask you how much of a distal extension Rumit's done on all-on-6? Good. And Rumit, Chris, and Sagendra, can I ask you if you can recall what the distal extension was on all your cases, please? Yeah. I think 1 unit at the most, and it's got to be. Can you tell me what size unit it was? Was it a premolar, molar, a proper molar, premolar? Yeah. So when you would have done this, of course you would have to be absolutely sure that the distal pontic doesn't take significant lateral stresses. In fact, you should really try and avoid putting lateral stresses on the distalmost pontic. And of course, it should be an infra-occlusion. So you shouldn't have it in what we call tight occlusal contact. It should be infra-occlusion. So in other words, your shim stock paper should definitely ride through when the patient clenches hard on the most distal pontic. You should make sure that when you're checking for shim stock contact, it's ideally just on the heads of the implants if you can. Very, very difficult technically to get perfectly right with your technician. But if you're spot grinding things in on your trial base, then you can do that. And then once you've got it absolutely perfect, you can send the stuff back to be glazed and just hope it doesn't come back, changed again, but it shouldn't do once you've got it right. So every prosthetic extension increases a risk factor. Using heads which are narrow, platformed, again, increases your risk factor. But of course, you need to balance all of that with aesthetics. You can see, I'm just going to change the color so that you can see. Pink color. Let's go blue. You can see here, you've got that's palatal, there's a buckle, you've got very, very little buccal volume here, and the same here. But there's an advantage to using a wide head, and maybe this particular case should have had a little bit of bone grafting buccally, so that he could have safely used a wide head. It looks like if there isn't a problem here, but they could well have been. Again, check your extensions on your pontic area and make sure that you don't have any lateral excursive points on these pontics. It should be free from them because you're increasing the stresses within your bridge significantly. The patient says, I don't feel I'm getting a massive bite on it. Give them a bite in centric and don't let them touch on excursions. Now, it may mean aesthetically your cusp heights would need to be quite small, and it may be your occlusal table is small. Well, so be it. It's better to reduce the long-term risk factors and explain to the patient why that has to be that way. Show them first before the bridge goes in, show them the wax up, explain to them why the bridge needs to be that shape. You can't always get the implant head exactly in the middle of your prosthetic crown, but the disadvantage of using big disadvantage of using these big ridge-lapped crowns, is that not only does it make it unstable, but it's a massive oral hygiene issue as well. If you've got a tripod arrangement, you are going to get this degree of prosthetic overlap, and so you've got to make sure that the patient in situations, you obviously don't want to tripod it too much so that you've got massive overhang or ridge lap. You just want a degree of it so that it's manageable. Certainly nothing as much as this. But if you are going to place a head which is significantly away, so the center of it is here and the head is here. So if the patient is gliding either side, you're putting much more stress on the internal screw, and it will lead to probably screw loosening. An excessive height of the restoration increases the levering arm, and if you've got screws, it can lead to more screw loosening. Now, I mean, this is what some people say. I don't find that all the time, but certainly I think if you've got a really large prosthetic component to the attached to the implant, which is almost, let's say, double, if you've got a screw in the middle of it and you've got any real good significant amount of force going through the implant, then it is a question of time that you're going to get some form of loosening of the screw. Bicon, of course. By the way, has anyone here tried Bicon as an implant system? No. Okay. Well, that means that I know Anklos have got an element of locking taper, which is essentially a Morse fit abutment, which has no screws in it whatsoever. But if you've never tried it, they have a system where you can put a short implant and you can put a very large prosthetic crown on this, and it all fits in with this 1.5 degree Morse taper. I've used Bicon in the early days, probably for a good 10, maybe 15 years, and I placed a lot of Bicon implants. And I would say they work really well. And certainly the only problem you have with Bicon is that if you do have an occlusal problem, the whole abutment just comes out neat. And then you can tap it back in, because that's how you put these back in. You just tap them in. And then once it's back in, then you can adjust the occlusion. There's no problem with screw loosening, because as we all know, once we've had screw loosening, half the problem is, unless it's a screw retained implant, to separate the crown from the abutment, if you've got temporary cement and the whole thing is moving, is quite difficult sometimes. So Bicon are good in the sense that they have a platform switched base, and they have very short implants as well. I'm not asking you to buy Bicon, or this lecture I'm not allowed to promote any implant systems, but I do want you all to look at other implant systems apart from the one that you're using, and look at the merits of them as well. It's part of the armory you should have up your sleeve. You're going to come across a situation where you're going to have to use a short implant, big surface area. You're worried about occlusal load. Could that implant work a little bit better on an occlusal load? than your implant system with the screw-based implant system. So I think all of you maybe should look at that as well as an option for patients with significant occlusal loads. Okay. Bruxism, parafunction, or natural tooth fractures are all big warning signs. So patients who you're assessing as your initial setup for possible implant patients, you're already looking at all the signs that could make your treatment difficult and possibly lead to complications. Lateral occlusal contact on implant supported only crown is a partial risk, so but really what you should try and do is make your lateral occlusal contacts on your natural teeth where it's possible. So you're constantly looking at, before the crown is being made, showing your technician where the lateral guidance contacts are and making sure they are duplicated again in your final restoration. In other words, your final restoration is not taking the lateral stresses. Let the patient know what the final thing will look like to try and prevent those lateral stresses going on your prosthetic crown, your final crown. Yeah, the etiology of your tooth loss is really a good way of working out what the occlusal state of your patient is. You've got to remember that if the patient's lost the tooth due to a fracture, midline fracture, if it's 2 or 3 teeth that are breaking, record that, see if you can at least make sure that the patient's able to wear a night guard, and then explain the risks involved and the possible risks with the implants and what could happen even if the implant were to be placed, and let the patients understand that they are considered high risks in those situations. So again, you want to try and put your implant as close to the actual axis as possible. That's the center of the head, and think about whether you should place either cementable or a screw retained. So I'm going to ask a question now. I'd like you all to answer this one question. If you had a patient who was a bruxist and there was good interocclusal clearance on a molar tooth, let's say a lower right 6, full dentition, upper, only tooth missing is the lower right 6, and there were bruxis, would you choose between a cement retained or a screw retained crown? Okay. Okay. So most of you are going for screw retained. So I want you all, I'm going to go through one by one. Let's see who started first. Just start with you, Chris. Why would you choose a screw retained, would you say? Okay, yeah, happy with that. I think what you mean, what Chris is alluding to, is the fact that if you've got a screw loosening, you would be able to take the composite off, take the PTFE tape out, take the whole thing out, and start again. For the people Govendra, you've said a screw. Can I ask you if you had the screw break because you've used screw retained, because all the pressure is essentially just going on the screw and the slight amount of hex. There's no abutment to protect you. What would you foresee as the main complication of using a screw retained crown on a bruxist patient? Actually, anyone would like to say what do you think is the main complication of using a screw retained crown on a heavily bruxist patient? Yeah, I mean, it correct. All of you've got it right. That's the only downside. Uh, yeah, correct. How to remove a fracture portion. Yeah, we'll go through that. I think we'll go through that, but that's the only downside. Iki, you said that you would use a cement retained crown. Yeah, that's it, Govendra. You got it right. You'd use a scaler, and with the scaling tip, what you would do is you'd put a very small, fine scaling tip, and you try and touch the screw with your scaling tip, and you sort of rotate your scaling tip in an anti-clockwise direction. So you essentially sort of giving the sort of making it want to turn out, and it usually just works. There's no point trying to put a slot in a slot. Yeah, you can use a probe, but sometimes you need, you can sort of try and just use a scale, and usually the ultrasonic usually just vibrates it out. To be honest with you, it's usually quite easy if it does break. But if the screw, and it should be a safety feature within the thing, so it only breaks at a certain point, so it's quite easy to unscrew it out. And hopefully what's happened is the screw has loosened a little bit before it shears off, and that's usually what happens. But Iki, you said it was a cement retained. That's not a wrong answer. What was your justification for using a cement retained crown, I wonder? Yeah, correct. Again, I've used cement retained as well as screw retained for this. Um, I think with the advent of more and more technology going into the screws, um, both work. The other problem is in this particular case, I said it has had a good interocclusal space. As soon as your interocclusal space starts to diminish, then I would say think about using a screw retained. The other thing is also the prosthetic fit on the implant head is better, much, much better for screw retained. But I think you've got to look as much as you can to perhaps thinking first screw retained, and then if you need a massive height on it, then it's better if you've got a big, large occlusal. I think if you've got a big, large interocclusal height and you need height on your abutment, then I would start thinking of a cement retained because you've got much more abutment retention there rather than a prosthetic screw holding a big head of a crown on. So the only thing you've got holding the whole thing down is one screw, whereas if you've got a big abutment screwed down, you've got the full force of the hex being engaged in your abutment as well. Okay. So the risk is elevated. The force are not transmitted to the implant axis. Of course, these occlusal patients are high risks, and some of you may be using a company that supplies, who out there supplies their components to their labs, and who asks the labs to order them in? I wonder. What, your lab orders them in? Yeah, both. Neil, labs order them, then don't get it wrong, correct. I do know of some labs who order, who don't genuinely order, but I supply for some might retain. Yeah, you may have been tempted to order from a company which I won't name that gives you copied abutments and a copied implant screws. And if you're tempted to use them, or your lab is tempted to use them, then you could be in trouble, essentially because the actual precision fit is nowhere as good as the genuine implant company, and therefore fractures, bending, that sort of thing is commonplace. I had a referral patient whose screw sheared off. We asked for the component prescriptions, and it was all the components were copied, including the abutment, the screw, and I would suggest that the probability was because the components were not genuine. Difficult to tell the patient as well exactly what components and which they are. They should be scanned and put into the patient's notes so that they form part of the clinical records, what components that you use. So we've talked about the occlusal contacts. They should be in the center with very low cuspal inclines, and always show that you're checking in centric and then a different color in excursions, just to be sure that you've accounted for the lateral stresses. Keep your occlusal table small, and if you are going to use a narrow implant, accept that you're going to have a very narrow occlusal table, and I've said to you, generally try and stick to a screw retained prosthesis unless your occlusal table is very, very large, or other height is very large, then you may have to go to a screw retained. But okay, so I've got this one case. What I'd like to do here is I'm not overly worried about this. Hang on, I'm not worried about this here, and what we should do. What I'd like to ask people is on where do you think the risks are for this particular dentist and what he's done in terms of prosthetic design? If you can just type in where this is a linked bridge. This bit here is linked. This isn't. So this isn't linked, and this obviously is linked. So do you want to just all of you just at least put down what do you think the risks there are? Yep. So Neil, you're quite rightly correct. Teeth connected to implants. Thank you, Rumit. Have a look at the pontics and there's occlusal problems, correct. I know there's perio issues there as well, but that's not. Just have a Chris is saying. So Chris is saying that if lower left 5 fails, not be able to cantilever forward as insufficient room for a new bridge, implant. Good. Upper left bridge, yeah. Caroline, can I just ask you, the upper left bridge, what do you feel is the issue there that you'd be most concerned about? Yeah. Yeah, Neil, happy with that as well. Chris, no contact upper right 2 appears to have an overhang. Yeah, just there. Betel bone between implants on the upper right quadrant. Yeah. Large pontic upper left. Yeah, that's it. That's what. Well done, Caroline. That's exactly what I was after. Is this is a high risk situation? Not only have they splinted onto a root canal filled, it's a large distal pontic, and you've added that on. Yes, this is a lot more riskier than the situation I was talking about. In this particular case, it would have been better to think about a sinus graft that area really well. Prognosis of that tooth, don't attach to something that carries a slightly poor slightly poor prognosis. Even if they put a precision attachment in there, I still would have been a little bit reluctant to advocate this at all. You pointed out that this, I don't think it's linked actually, it may be linked, but again, we all know that the position of the implant is so important. The head of this implant here could have been a bit more central here, and therefore this large interdental space could have been avoided. The problem here is, of course, you're quite right, he's got that little problem there. There's lots of other issues going on, but it was quite rightly pointed out by Chris, I think, who said that this is an indicator that the patient's got massive occlusal problems. Well, of course, the patient's got anterior crown, so it could be wear from that, but again, dentist is trying to restore the posterior stability as much as he can, but this area here is probably of the major concern. It looks like what they've done is he's tried to do a whole bridge. I can't see a break in there. There may be a break, but it may be connected all in one, but not quite sure really what's gone on there. Could be physiological wear as well. Yeah, correct. Okay. Here's another. Again, have a look at this and could you just write down what the risk factors here are and what they've taken on. If you just type in at least one or two things each, correct? Periodontal disease, Chris? Just 1 second. Big pontics, yep. Lower connected to teeth rumit, thank you. Too few implants in space, too narrow implants, yep, good. Single piece implant, icky, yep. That's not good, is it? What else is there? Single piece. Long span implants. So again, good. Okay, should have stabilized the patient before starting complex treatment, correct. Okay, I think that's everyone. So let me start off by, let's do a complete treatment plan on this patient, okay? This patient presents to you in your practice as it is right now. Patient's not got any relevant medical history. He's not a smoker. Money is not really a decay on the 2.7. Yeah, just there. Let's just go through a treatment planning exercise here. Is there any evidence that this patient is a bruxist from what you can see so far? Excuse me. You say, guys, and it's difficult to tell straight away, but evidence would you say that the patient is a bruxist? Would you take a chance? Yeah, flat occlusal plane and molars, possibly flattened cusps on the upper left quadrant. Yeah, correct. Yeah. I think when you have a case like this with excessive multiple spans, and you can see quite a lot of enamel being eroded, and as been pointed out, there are quite flat cuspal cusps there. The patient is a perio patient. You've got issues going on there. You've got furcation involvement here. What would all of your first line of action be here? What would you all want to think about doing first? Yep, good OH. This is articulated study. Yeah. Obviously sort out, yeah, well done, Neil. Basically, you need to sort out the active perio, control the periodontitis, hygiene, yeah, absolutely. And yeah, remit tooth by tooth assessment as to the prognosis of each tooth, and individual support actions around those teeth, and which ones can be saved and which ones can't. My view is don't get involved and tempted to, yeah, Michigan Splint as well, tempted to take on big, advanced, restorative, complex implant cases such as this. Just stabilize them. Also, very tempted to suggest to you all that cases like this, you should get a second opinion as well, and make sure that you've covered all bases if you are going to take them on. You shouldn't be really looking to do more implants on this patient at all until you've actively stabilized everything, got out all the decayed teeth, checked all the mobility out. If the patient is not suitable, it's not suitable for what you feel is advanced implant work, then certainly don't try and be tempted to place more implants on this type of patient. Just maintain, monitor, and cure what you can cure, but don't make things much worse for them. I think it's very tempting to have patients coming through the door and saying, oh, well, money's not object. Can we just go ahead and do things? Tell them exactly. If you feel that you can't meet the patient's expectations with your philosophy of treatment, you should refer the patient on and ask them to perhaps seek another practitioner's opinion on this. Again, this particular case, have a look here, tell me what you feel is the risk factor to a degree that's happened here. Multiple implants close together. Yeah, good. Large spans underneath bridges. Yeah, not. Yeah, you have got some large spans, Caroline, here. And yeah, along here there's quite a large span as well. So I agree with you. And same thing here. Full, and it looks like a full bridge. I think these are individuals actually. Second is underneath lower right 3 and 4. Yeah, Rumit, correct. I think that's happened. And here, of course, it's difficult to tell you where they've linked, but they're definitely linked to this. That's right, it's splinted. So they're definitely linked to this tooth here. Difficult with the X-ray. I haven't got a very accurate X-ray here, so that's sort of a danger sign. But all the things that you've occlusion not assessed before and articulate, yes, go Sugendra. It may be difficult to say, but it all looks quite flat. Again, it looks quite splinted as well, and they've done a big span bridge on 2 abutments either side here as well. Maintaining oral hygiene between single implants, supported restoration. Yeah, so yeah, we've got yeah, Neil, I agree. Okay, let's have a look here. Again, I mean, this slide really just says it where it is. You're going to have a look at the natural axis of the adjacent teeth, okay, and work out where you feel the right axis for the crown needs to be. So when they're orientating your surgical guide for you placing the implant, you can only really tell by the orientations of the roots. So you should be telling your technician from the PAs and from the OPGs roughly the direction you feel that the head of the implant needs to be following. Technician might say to you, right, well, that's the path I want you to choose. So you'll end up placing the implant. That's exactly what's happened here, when really the implant orientation needs to follow to a degree the adjacent roots to keep the occlusal form. Now, that doesn't always apply, but generally that's the rule. Can I ask how many of you talk to your technicians about your occlusal stents for surgical guides? Do you talk about the orientation of the root form at all? Okay, Neil. Icky, no, sometimes, and not usually. So it's I definitely want all of you, no matter how experienced you are, to use a surgical drilling guide and take a picture of it. You get so if you're doing an occlusal stent, if you're doing like a CBCT scan, you use that radiographic guide, same guide you can use as an occlusal guide, as a surgical guide. The reason is it's very, very difficult to defend your position if the standard is to produce a surgical drill guide. And that is the standard, by the way. So please get a simple acrylic surgical. It's less. Honestly, I think it's something like 20, 30 pound to get one made. Charge the patient. I charge them about £110 for it. It's a radiographic guide and a surgical guide. And I would say, Neil, yes, please use a surgical or combine it with a radiographic and a surgical guide. So basically, you tell your technician, right, do a wax up, make me a surgical guide. Okay, he'll make a surgical guide. All you do is take a little bit of amalgam, make a small little hole on roughly where either on the buccal or the lingual of that surgical pontic area. Put the amalgam in, seal it off, then get the patient to have their CBCT scan or an X-ray, so that you've got your stent, so you've got your radiographic stent and position of the prosthetic head, and then use the same guide. Take a picture of it when you do your surgical placement to show that you used your guide as well. What do you ask, Blank? Because I don't usually use a guide. You ask, that's, as I said, Chris, you ask the technician to wax up the tooth. You give them an idea of the root shape. You can say to you can tell them roughly what angle the roots are. You can even send them an X-ray as well, and they can then wax up with the same orientation as what you've asked for. But all of you must use it, because I've seen enough litigation cases where you will be found wanting if you haven't shown the right planning involved. If you look at some of the GDC cases that are coming through, that's a big area. So please start using them. Charge for them. Tell your patient it's going to cost, as I say, I charge about £110. Lab kit is probably about £25-30. Might be a bit more, but it's well worth it, and just make it part of your protocol all the time. Right. I think is there any questions, anyone? We've come to the end there. Is there any questions that you'd like to ask? Good. So great. Could you all leave? I'm sorry if you feel I didn't have much juice in this one, but I just felt that, and a lot of the things I've covered today does seem quite basic, but I really do feel that these are the sorts of things that are repetitive in terms of problems over the years that you're going to be doing implants. Once you start doing implants for about 10-15 years, the patients who you've placed implants for years will gradually start coming back. So I'm hoping that this lecture was purely based on the problems that I've been having over a long period. So good to see that you all found it really useful. If you have a massive problem or a repetitive problem on a patient and you can't figure out, just bring it to my attention, and I'll see if I can help with the experience I've got. Okay, guys, thank you very much for the feedback. What we're going to do now is, the next time, Neil has kindly agreed to give us his talk on PRF, which is going to be on the 29th of March. I'm going to be on an annual leave now for about 2 weeks, and then I've got to obviously I've got to mark the module assignments for the Squirm module. So the next meeting actually now will be on the 29th of March, and I'll let everyone know, and of course Neil is going to do that. So please, let's all be here to support Neil. Anyway, good night, everyone, and look forward to seeing you all soon. Take care. Good night.